Movement Desensitization and Reprocessing, EMDR. Now I say that slowly because I'm really quite ignorant
Well, it sounds like a computer game, doesn't it?
It does a little bit. It does a little bit. And I did have a little bit of time finding out actually just what EMDR stands for. I will just say that I currently have a friend that Carolyn knows about who is actually being treated for by this method of treatment for post-traumatic stress disorder, and is receiving enormous benefit from it. I will just say that. So right away, I think we need all the weapons, if you want to call it that, in our arsenal that we possibly can against mental health problems, and I'm absolutely thrilled to think that this might be an effective method of treating post-traumatic stress disorder. So obviously it's a fairly new, non-traditional type of psychotherapy, and correct me if I'm wrong with any of this. It's certainly growing in popularity, particularly for treating post-traumatic stress. And certainly for our veterans of combat experience, people that have experienced domestic violence and rape. I believe it's being used for especially. Carolyn Burrows, this lady in front of us here, is a clinical social worker and psychotherapist. She's had 12 years experience providing therapeutic services and has worked in community, hospital, university and private settings. Carolyn specialises in the treatment of post-traumatic stress disorder in adults and adolescents. She is the EMDR Program Coordinator of the Melbourne Clinic. So that's this clinic. If you're not aware of exactly where you are, this is the Melbourne Clinic. And also works in private practice. She is an accredited EMDR practitioner and supervisor, and is currently Secretary of the EMDR Association of Australia. So we're very privileged to have somebody that obviously is very authoritative in this technique, in this mode of treatment, and can give us very informed and expert advice on just exactly what it is, the benefits of it, and I think I'll just turn it over to you now.
Thank you, Jim. I really appreciate that. Well, I'm very grateful for the opportunity to speak to you tonight about EMDR. And my first slide really was going to be an introduction of myself, but I feel that Jim's done a really fantastic job of that, so thank you very much. I do work here at the Melbourne Clinic. I also work in a private practice called Mindful Living, which is in the eastern suburbs in Croydon, where I do specialise in the treatment of post-traumatic stress, particularly using EMDR. So before I get into my presentation, I just wanted to get a bit of a sense of who you are, because I don't know a lot about the Mental Health Foundation. I'd certainly heard of you, and Jim shared a little bit with me when we spoke on the phone, but I would just be really interested just to get a bit of a sense as to how many of you work in the area of mental health. Just a bit of an indication, okay? And for those who don't, are you people that are interested in mental health from your own, either own personal perspective or for family or friends? Yep, beautiful. So there's a bit of a mixture here, which is really wonderful. And I'd like to say at the outset that I've had my own EMDR treatment, which is very much encouraged for people that train in EMDR. When we do the training ourselves as clinicians, we practice with each other a lot. And I then went on to actually see somebody myself, because I find that the best way to learn something is to experience it. And so I've been in both chairs, if you like, as the EMDR therapist and also as the EMDR client. And I can say from both perspectives that it's a really, really interesting method of therapy. And so I hope that tonight is both relevant for you if you are a mental health practitioner, but also if you have an interest in EMDR from a personal perspective, or for somebody in your life that you think might benefit from this method. So I'll certainly tailor my presentation to both groups, and what I would really hope would be that this would be an opportunity to ask questions and to speak quite openly about this method. I'll be presenting on the method from a perspective of both what it is, because as Jim was saying, it's quite a curious term, EMDR. So what it is and some of the underlying theories behind it and effectively how it works, because I think that's probably what most people are interested in, because it seems quite exotic, but what actually happens in EMDR treatment. And then I'll also be sharing with you a bit about the program here at the Melbourne Clinic, because I've established that program and coordinate it, which is an inpatient EMDR treatment program. So people come into the hospital for a month. And then also what other options are out there in the community if you don't feel that the inpatient model is most likely to be suitable for yourself or family, friends or your own clients. And then also finally, for those of you who are mental health practitioners, how you can go about training in EMDR, because unfortunately tonight's presentation will not equip you to practice EMDR. It'll be a little bit to whet your appetites. So certainly there'll be opportunity to talk a bit about training opportunities, and we can certainly discuss that privately if anybody has any questions or would like to discuss, your own personal circumstances and whether it's something you might like to train in. So before I get into what EMDR is, I'd like to just get a bit of a sense from you as to who's actually heard, beyond just what the EMDR acronym is, who's actually heard much about EMDR? Yeah, well, what have you come across?
Well, I've seen it talked about in some of our hypnotherapy sessions.
Okay.
And some people have demonstrated it, so it's just, all I remember from it is that you just follow somebody's finger with your eyes, and somehow it scrambles your brain to, wipe out the past.
Yes.
That's just very basic. And I've had a look on YouTube as well.
Okay, yes.
I've also got a book at home.
Great.
But I would love to just learn it properly.
Beautiful. Yeah. Absolutely. Yes. What about others? Obviously, you've come here tonight with some interest in this. What have you heard about EMDR?
It was just part of our course.
Okay.
I'm clinical hypnotherapist.
Oh, beautiful. Yep.
So it's just one of the many techniques in
great.
EMDR,
Okay.
but very basic.
Yes.
Then spend 2 weeks on a running.
Yes,
It's
yeah.
just an afternoon.
Sure.
So, but still, it's where I've heard of it, and we'll
Yes.
just basic practice with it.
Yes.
And that was it.
Well, I'm delighted that it's even covered in the course. Yes.
Yeah. That was a technique.
Yeah, that's great.
I
Fantastic.
thought it was a bit weird at the time.
Yes. Oh, as did I before I trained in it.
Your fingers.
Yes, absolutely.
But I was all
Yeah.
at it back then. So.
Of course. No, well, it is a bit weird. In a great way, but it is a bit strange, and that's what makes it unique, and that's what makes it really quite exciting and very much a point of some interest at the moment. So, anyone else like to make any remarks about what you've heard about it?
Well, just ditto what's already been said.
Yes.
I mean, we covered a bit of MDR in the course in therapy.
Yes.
And I've seen various snippets around, so I thought I'd come along and find out a little bit more.
Fantastic. Wonderful. Anybody else?
So I did a course that was similar to EMDR. It was called Visual Repatterning something or other. And supposedly at the time they couldn't use the word EMDR because you had to be a psychologist.
Oh, I'm not sure.
So anyway, it was a short course and I just found it amazing. So I just sort of hear a bit more about it.
Yes, absolutely. So EMDR has a bit of a name for itself as being a little bit kind of curious and almost exotic, and that means that some people are super interested in it and other people just discard it, I think. So what I'd really like to do is just share a little bit of both the science behind it, some anecdotes around how it can be really helpful, and also to talk a bit about how it actually works, because I think that's most interesting to us. So EMDR therapy is most well known, of course, by its eye movements, because that's what makes it quite a unique treatment model. But EMDR is actually an 8-phase model of treatment. And what we mean by 8 phases is it's not simply just a person sitting down and just processing their traumatic memory. It would be wonderful if we could do that safely and effectively that easily, but in actual fact there are some steps, of course, to prepare us for that. So it's quite a comprehensive treatment approach that's not the kind of the magic cure that people sometimes think that it is. And I think that's probably one of the things that I encounter in my work a lot, is people come wanting this treatment expecting that it'll just solve their problems in 1 or 2 sessions. And so that's not the case. Having said that, it can be very rapid depending on the circumstances.
Sorry to cut you off in your flow. Are you happy for us to take pictures?
Absolutely I am. And in actual fact, Jim, I'm quite happy if you would like me to send you the slides afterwards and you can distribute those. Absolutely. I wasn't quite sure how that works. So very, very happy for you to take notes, and I'll make the slides available to you. So what EMDR is designed for is targeting or processing traumatic memory or adverse life experiences that have become stuck in the brain and the nervous system, if you like, or are unresolved. And I'll talk a little more about how that happens. And it's particularly useful for post-traumatic stress disorder, but also increasingly is being researched for a range of difficulties or mental health diagnoses where there is some underpinning that stems from adverse or stressful or traumatic life events. So not everybody that experiences trauma, things like bullying, for example, or neglect or assault, not everybody is going to go on to develop PTSD, but they may well still have some legacy or some aftermath of those experiences that affects the way that they see themselves, others and the world, or they may have intrusive experiences, things like nightmares or disturbed sleep or thoughts that are really intrusive, or they may have a high level of emotion attached to painful experiences in their life. So really, anybody that's experiencing any of that may well benefit from EMDR, but its particular focus initially was the area of PTSD, and that's where it has the most level of empirical research. It's indisputably evidence-based for PTSD now, as I'll go on to describe. So it's been developed by somebody called Francine Shapiro, who is an American, and it was in the late 1980s, and it's all a bit curious as to how it came about. She claims that she was walking in the park one day and was feeling quite disturbed by something or quite upset about something, and that her eyes started quite spontaneously moving left to right, and she found that when she kind of allowed that naturally to occur, that she started to feel less distressed. And that was a bit interesting to her, as of course it would be to anybody. So she went on to do some studies, and then from there it really developed. Now initially, I must say, she was quite heavily criticised. She's a psychologist, so I guess people, thought this was a bit hocus pocus. But progressively over the years, as you can see, almost 30 years, there has been an increasing level of research that has resulted in really quite a widespread respect for EMDR, particularly for PTSD. So EMDR is based on a theory or a model that is called the Adaptive Information Processing Model, which I won't go into great detail about, but I will just speak to briefly, just to help us understand what is this based on. So EMDR is underpinned by this idea that when we experience a traumatic or really stressful event, that because of the high level of emotion and sensory or somatic experiencing that goes on in the body, the fight-flight response, for example, because of the high level of emotion that goes with that experience, then the brain's capacity to process that event is impaired. So it's not able to process and resolve that experience in the same way that it would ordinarily. So we have a smoke detector, if you like, in our brain, which we call the amygdala, and when we're under threat or when we are feeling highly stressed, that part of the brain gets highly activated, which signals the autonomic nervous system, particularly the sympathetic nervous system, to kick in. We go into fight-flight. There could be freeze and other responses too. And then what that does is it means that other parts of the brain, particularly the hippocampus, that we can think of a bit like a librarian that puts a time and date stamp on a memory, gets impaired, and so the brain isn't able to process that memory appropriately. And so what can happen is that it ends up being free floating in time. So rather than having a sense of it happened then on this date and it gets filed away, it can feel as though it's happening again and again when we get triggered. So what sort of things do you think can trigger a stressful or a traumatic event long after it's passed?
Assault.
A similar situation.
Yes. So an assault might be an incident itself, and what might trigger the reminders of that long after it passes?
But it might be similar circumstances.
Correct, yes, yep, absolutely. And you were about to say that, were you? Sorry, yes,
a
yep.
similar situation.
Yes.
Feels threatened.
Yes.
Everything comes back.
Absolutely, yes.
Or what if it was to do with the war or something?
Yes.
Just fuel when you go to the petrol station.
Correct, yes. So it can be very visceral. It can be olfactory, it can be visual, it can be auditory. There can be a whole range of things that mean that the brain responds as if we are back in that situation. And so I often say that the amygdala or the smoke detector becomes oversensitive, a bit like a smoke alarm in our house that goes off when there isn't actually a fire. Have any of you had a smoke alarm that gets a bit overexcited when there's some toast burning or something? Well, our brain can respond in a very similar way, which means that the brain and the body respond as if we're under threat, which means that we're almost being traumatised on a daily basis. And that's obviously incredibly distressing for us. And what can also happen is that the memory and the associated emotion gets stored in an isolated memory network. So what that means is it's sort of trapped somewhere in the brain and not linked up with more adaptive or positive experiences. So for example, we might have had many years of being able to trust people, and then suddenly we get assaulted, and then that memory gets so kind of amplified and is isolated from all these other experiences that we can feel as though nobody can be trusted. And so in EMDR, we're helping to link some of those things back together again, so the more adaptive perspectives can start to come on board, which is wonderful. And so as a consequence of these neurological and visceral experiences, things like post-traumatic stress disorder or depression or anxiety can stem from trauma. And to be perfectly honest, I don't think any of us are immune to trauma. I think we've all experienced something in our lives that's been traumatic. There's a whole lot of factors that will determine how we respond in the aftermath. And for some people, something will lead to a diagnosis of, say, post-traumatic stress, and for others, it won't. So it's really variable depending on a whole range of things. So let's talk about what are those 8 stages of EMDR therapy. So people think of the eye movement component, which is really phases 4 and 5 particularly. So it's quite interesting. There's actually a whole lot of other scaffolding around EMDR. So what we do in an initial session for EMDR is, of course, as you would whenever you see a client, or if you're not a therapist, when you go to see a therapist, would be, of course, history taking and getting to understand the person's situation. So in EMDR, that's not that dissimilar to other therapy approaches, but what we are doing is we're really keeping an eye out or a lookout for what might be some what we call targets for EMDR. So what might be some key events in this person's life that have contributed to their presenting difficulties, and what are some of the negative beliefs or some of the ideas that have really influenced this person's experience. So we're really looking out for those, because that's what we're going to target in EMDR in the desensitization phase, which is the eye movements. So then in preparation, that can be anywhere from 1 session through to many months, depending on the complexity of a person's situation. So preparation involves everything from just talking about what's going to happen in EMDR, right through to teaching skills to manage painful experiences like thoughts, feelings, sensations. Because as you can imagine, when we start to process trauma, it's quite uncomfortable, and so we don't want the person to be feeling overwhelmed by that experience. We want them to be able to safely stay within what we call the window of tolerance, which means that they're not overwhelmed nor are they really shut down. They can think and feel at the same time. So that can be things like teaching deep breathing, or there's often an idea we talk about calm place, so teaching the person how to visualise a place that is settling and soothing for them. And there's a whole range of other things depending on the complexity of the situation that may be covered. And then 3, 4, 5 and 6 are really the main bulk of what we would consider the main hallmarks of the EMDR treatment approach, because what we're doing then is we're identifying, well, what are we going to focus on? So in the target assessment, we're deciding what's a memory or an incident that we're going to start with. So for single incident trauma, like for example a sexual assault or a burglary or aggravated burglary, for example, it's quite straightforward. But for a lot of people, it's not straightforward, is it? Because we may have experienced bullying and neglect and violence for many years. So EMDR can be used for both complex and simple PTSD. It just takes a bit longer, obviously, when it's more complex. So we decide what would be the most important matter to start with, and so usually that's determined by the person's presenting problems. So if a person, for example, comes in and says, look, I'm so anxious that I can't even get in my car, and drive because I had this really horrific incident, well, obviously you know where you need to start. Whereas if they've got 10 difficulties, you might determine, well, which is the one that's most distressing or most impacting on your functioning at the moment. So we work together with the client to decide what memory would we want to start with. And the great thing about EMDR is they don't even have to talk about it in any great detail, which makes it quite different from other methods such as prolonged exposure, where there's a much more involved process of retelling the story. In EMDR, we don't do that. We just ask them to identify very briefly what's the event, and then we ask them to identify an image that represents the worst bit of it. So it might just be what's the photograph in your mind, if you like, of the worst part, what thought goes with it, negative thoughts, that might be I'm not safe, I'm not good enough, I can't trust people, what emotion goes with it, where you feel it in the body, and then we move into desensitization, which is where we get these eye movements going, and I'll talk more about that in a moment. Installation is once the distress has come down with that memory, then we start to what we call install or integrate some more positive ways of thinking. And the thing about EMDR that makes it different from, say, cognitive behavioural therapy is that while there is a cognitive restructuring structuring part to it, like we're trying to change thinking. We're not doing it in a way where we're challenging thoughts. The brain quite naturally and organically starts to come to new understandings. And that's because that memory is no longer isolated. It can start to link up, as I said before, to some of the more, I guess, adaptive perspectives. Like, oh yeah, actually there's many times in my life that I've been safe. Or there's lots of people that care about me, for example, and they can start to shift thinking. With a body scan, we then just check out what's going on. Are we, is it fully resolved? Is there anything remaining? And then we move into closing up the session. And then the following session, we reevaluate and we check in. So all of that can happen in anywhere from, maybe 3 sessions right through to a progressive period over a lengthier period of time. As I said, that preparation phase is the one that really is most variable. Sometimes just 1 session, sometimes months, depending on the complexity. Like if a person's suicidal, for example, you're not going to go in and start processing their traumas straight away. You're going to do some work to ensure that they're safe. Does anybody have any questions before I move on, just about those phases? I am going to go into more detail, of course, particularly about the desensitization and what happens, but just any preliminary questions? In EMDR, we don't just focus on past trauma. We start with resolving, where possible, the past experiences, but then we move on to any present triggers. So it might be, for example, if a person is struggling with intimacy with their partner. If they've been sexually assaulted, for example, we would start with memories of the assault itself and any surrounding circumstances, going to the police or not being believed or being judged, for example. And then once we've resolved them, if the person's saying, look, I'm a lot less disturbed by those memories, I'm not having nightmares and flashbacks, but I still feel a bit frozen when my partner tries to be intimate, then we would focus on present triggers. And then what we call future template is we invite the client to imagine coping, and we do some really lovely work basically to skill them up and resource them. So there's 3 prongs, if you like, to EMDR, which makes it a nice comprehensive treatment. So what I'm referring to here is once we've gotten into that desensitization phase. So this isn't the whole of EMDR, this is once we're in this processing part of it. Does that make sense? Yep. So once the client has identified what they'd like to work on, as I said before, we get them to think about it and where possible to feel disturbed. Now that's quite counterintuitive, because I think a lot of us are trained to try to calm and to settle and to support our clients. Whereas in EMDR, you've got to be a bit brave, as does your client, because we're wanting to bring it up because we need to process it. But the thing we're really wanting to do is to keep it within that window of tolerance. So we don't want the person to be overwhelmed and losing it. We want them to be feeling like they've got 1 foot in the present and 1 foot in the past at all times. So we're never wanting the person to feel overwhelmed, because that's not therapeutically appropriate, and the brain would not be able to process it because the thinking part of the brain would go offline and have a holiday because the smoke detector is going to be firing. So once they've brought it to mind, what then happens is they notice the thoughts and the feelings, sensations that go with it, and then the therapist has this rather interesting job of getting the client to rapidly move their eyes. And so I had some videos that I was going to show you, but unfortunately the system's not behaving itself at all tonight, so unfortunately none of my videos are going to be able to be shown, so I'm going to give you some links to look at, which will mean that you can look at them later. And so what happens is in an EMDR session, we sit quite a bit closer to the client than we would ordinarily in other types of therapy, which in and of itself is a bit of a departure from what we might be used to doing. So we set that up, and in the preparation phase, we've made sure that the client's comfortable with the distance. And then what happens is that the client calls to mind the memory and they notice what's coming up. And then we do these sets of 30 to 60 seconds where either we move our hand or we use either a pen, or there's light bars that you can purchase. There's a range of ways of doing it. And the client tracks with their eyes rapidly while they are noticing what's coming up. And it's like a free association process. So they're not being asked to hold on to the memory and not let it go, nor are they trying to censor it. They just start with what they've got. So think of it and then just notice. So it's this dual awareness. So at the same time that they're thinking about it, they are tracking with their eyes, and let whatever happens happen is the instruction. So we have these sets of 30 to 60 seconds or so where the client's just following along, and you're not talking during this process. The client's just following. And you as a therapist might be saying, things like, you can do it, you're doing really well, just noticing, just observing. And then you pause after that period of time. And you're trained obviously to know sort of how long to go for. It depends on what's happening for the client. And then we pause with these little periods of reflection in between. And when you do pause, you'll say to the client, well, what do you notice now? And that's really hard for a person to answer sometimes because they don't know what to say. But you've said to them before, what I mean by that question is, what do you notice with regard to any thoughts that are coming up? any feelings that you might be noticing, what's happening in your body. And then, depending on what the client reports, we either just say, okay, just notice that, and we do another set, or we might intervene in another way. But generally what we're trying to do is just let the client's brain process it. And I'll explain in a moment how that's believed to work. And so that process continues until the memory starts to become less disturbing. And it is actually quite remarkable what happens. I, for example, had a client who came to see me with great disturbance because her son had attempted suicide and he had been very, very close to succeeding. He'd been in a coma as a consequence for a week. And so she'd very, very nearly lost her son. And so as a result, not surprisingly, she was so hypervigilant and so terrified that he was going to do it again that she couldn't sleep. She was effectively just on watch constantly. And in the EMDR process, she went from, it was within 2 sessions, she went from feeling like it was her fault that her son had attempted suicide, that she hadn't been there, that she hadn't picked up the warning signals. She went from believing that it was her fault to, by the end, without me even trying to make this happen, because I didn't know this was going to happen, she came to a point that she believed it was actually a blessing that it had happened, because it meant that after he attempted suicide, he survived, that he finally hit rock bottom and got the treatment that he needed, and now was engaging in treatment and was now much, much more on the path to recovery. So, I mean, that's quite a remarkable turnaround. And that memory of going to the hospital, not knowing whether he was, you know, okay or not, that memory was no longer disturbing. So I don't know how you explain that exactly, other than there's something going on in the brain to help to shift that process so that it's no longer stored in the same way that it was when it was maladaptively stored, I suppose. So this process of reducing the vividness and the distress of a memory and increasing the new positive beliefs, that process can take anywhere from 1 session, or even less than a whole session, right through to multiple sessions depending on the complexity. So for some clients you may chip away at a memory over a period of time. For others there can be quite a remarkable transformation in 1 session. So what I always say to people when I consult and supervise is, this isn't magic. You know, people talk about it as if it is, but it's not. It's remarkably effective, but nothing is magic. So we do need to be very respectful to the client's complexity, because that's just the way that life is. You know, things are challenging. We need to give it due time. Now, what's really important to know, particularly those who work in hypnosis, hypnotherapy, is that EMDR is not the same as hypnosis, hypnotherapy. The client is not being put into or induced into a deep relaxation state. The person is fully alert and awake the whole time, and they can say stop at any point, and it's a very active process, which makes it a little bit different. Any questions about the desensitization phase? Okay. So EMDR is beneficial in a range of ways, but usually I would say 3 things usually occur as a consequence of a successful EMDR treatment. The first is that the experience becomes less upsetting, so the person can think about the event in their life and not feel disturbed by it in the same way. Now, don't get me wrong, if it's a really, really disturbing experience, you're not going to think, oh, that was a great day, but you'll get to a point where you can remember it rather than relive it, which is a very, very different situation, so that the sting is taken out of it. Secondly, it becomes less intrusive. So what that means is things like nightmares and flashbacks either cease altogether or reduce in intensity and frequency. And thirdly, the beliefs that the person has about themselves, others and the world start to become just much more present focused and much more adult, if you like. You know, people can often feel like it's their fault that their parents separated or something. As an adult, we know that's not true, but they still have that very childlike belief because it's all bound up with the emotion of that experience. And so that's an example of I did the best I could, or it wasn't my fault. That's a new belief that can organically start to emerge. And so as a result, people's experience of things like shame and guilt starts to shift, and they're able to cope much more effectively in the present without being triggered nearly as often, which of course then increases functioning. People can start to enter relationships or engage in the workplace again, or visit places that they previously avoided. And we know that avoidance is often a big part of PTSD, so it's very important for us to be helping to overcome that. So EMDR has been very widely studied now. So it was developed, as I said, in the late 80s. Originally it was considered to be hocus pocus, but certainly since that time it's now indisputably evidence-based for PTSD particularly, and it's been found to have a range of effects on the brain. As you can see, they're around vividness, arousal, attentional flexibility, the capacity to retrieve a memory, distancing from a memory, and even memory association. And as you can see there, there's also changes that are found to occur in certain parts of the brain, which I won't go into a lot of detail because it's a bit theoretical for tonight. But things like the amygdala, which is that smoke detector that I mentioned before, starts to be much less oversensitive. And the hippocampus, that librarian or that time and date stamp, part of the brain that helps it to be like that happened then in the past, it's not happening now, can come back on board. And so there are three main, theories or ideas around why EMDR works. And I will say, though, that we actually don't understand neuroscience in all its complexity. So even though we believe that we know why EMDR works, and there's certainly been MRI scans and studies that have demonstrated certain things, we actually don't know. We do know that it works because evidence has demonstrated that, but we don't know exactly why. But three theories. The first is around the idea of rapid eye movement sleep, that the eye movements in EMDR help to activate an orienting response and are quite similar to the brain's natural processing system that occurs during the rapid eye movement phase of sleep, which is when we're dreaming. It kind of makes sense because when we're dreaming, we're often, stressed about something, and our eyes are actually flicking left and right. If you watch someone while they're sleeping, which is a bit creepy, you might see that their eyes are the eyeballs are sort of moving under the eyelids, and the brain is naturally trying to process. And so what I love about EMDR is it's actually helping to kickstart the brain's innate healing capacity, which is really lovely, and we're just the facilitator of that process. Secondly, the eye movements are believed to assist with what we call taxing working memory. So when we have a memory that we recall and we bring it into our short-term memory system or our working memory, if we then add the rapid eye movements, then the brain has to process a lot of information all at once. It's trying to think of something plus follow the eye movements, and it's a whole lot of stuff that kind of bombards the memory. And so what that means is the vividness of the memory starts to kind of wear down because the brain can't hold it as tightly. Quite remarkable. And the third thing, which is now, I suppose, less popular an idea, but certainly there was some studies were done, is that there's a sense of increased connectivity between the hemispheres of the brain. So that helps with, adaptive information starting to link in with the memory and a whole lot of things. So there's a few different ideas about why EMDR works. So how effective is it? So there's more than 30 randomised control trials now that have demonstrated how effective EMDR is for PTSD, and more recently it's been empirically evaluated for other things like depression, anxiety, even personality disorders, a range of different things. And more evidence will be needed to really get it up to the same level as it is for trauma or PTSD, but certainly there's a lot of anecdotal experience. I mean, I use it in my practice for really anybody, as I said before, that has an experience in their life that has contributed to some of the difficulties that they're having in the present day, which, unless we have, an organic depression or there's some genetic reasons or there's been some, I suppose a drug-induced psychosis or something, usually there is some environmental or circumstantial contribution, from our life. I think we are who we are because of what we've experienced to some degree. So these references will be included in your handouts, which of course you'll get. So if you're interested in looking up any of the research, then you're certainly welcome to do so. And EMDR is now endorsed by the World Health Organization and through a range of other councils and organisations as well. So if you were a little concerned about this being, a little bit sort of wayward, it's certainly very mainstream now. Interestingly, it's considered to still be a new therapy, which is kind of curious, isn't it? Because it has been around since the late 80s, but it's much, much more well respected now. And I remember when I first did my training, I thought that it was a load of bollocks, and I'm not quite sure why I decided to eventually step outside of that and try and learn it and see what it was like. But most people feel a level of both interest and scepticism, as I said, but certainly I think now there's a lot more wide interest, I suppose, in it. And it's particularly being well used among veterans and emergency responders or first responders like ambulance, paramedics, police, etc. The video that I wanted to show you certainly focused on that, which is something great to look at later. So a criticism of EMDR has been that, well, it's no different to other methods of exposure therapy. And so, it's not better, worse or anything, it's just different in my opinion. And a few of the differences from what I've gathered are firstly the unique eye movement component, but also, as I said before, in EMDR we don't need to talk about the trauma in nearly as vivid a way as we might need to in some other forms of exposure therapy, which for a lot of people means it's less traumatizing and they're less likely to drop out. So Exposure therapy and EMDR are on par, both very, very effective with PTSD. So I'm not saying that exposure therapy is bad, but I do think that there are some differences. And that there's no direct challenging of the person's beliefs, which there is certainly in CBT and other forms of exposure. And we don't have homework in quite the same way, which certainly means that clients do often buy in a bit more easily, which is quite helpful for us. So this is the video that I would love you to watch, and so certainly you'll have this link in your handouts that I will email around, which basically was an ABC report which was talking about EMDR and how it works. So I just wanted to speak briefly with you now about EMDR here at the Melbourne Clinic, and then other options in the community, and then training, and then we'll just have a bit of a general discussion and questions if that would be helpful. So I was involved in establishing the first inpatient, so hospital-based EMDR program in Victoria, and that was in the last 8 months that I've been involved in developing that. So I'm very, very excited to be a part of this program. And we've based it on a program that's at Pine Rivers Hospital, which is in Brisbane, and they've had a really great uptake and great success with this inpatient program. So it started here at the Melbourne Clinic in October of last year, and our pilot program has just completed, and it's going to be a permanent program as of the start of this new financial year, which I'm thrilled about. So I have a team of 8 EMDR clinicians that I supervise and enjoy this role thoroughly. So what we do here is we have an inpatient program that involves patients coming in for 4 weeks for quite intensive EMDR treatment, and 2 weeks beforehand they have a pre-admission phase in their home where they have a face-to-face assessment appointment, they have a workbook that they go through at home, they have phone contact with me as the coordinator of the program, and then they come in for a 4-week admission. And during that time they have twice weekly 90-minute EMDR treatment sessions that are one-on-one, and that's with the same therapist each time, so 8 sessions across the 4 weeks, and then each day they go to group therapy sessions that are trauma-informed. So that's a range of things like grounding, mindfulness, psychoeducation or in understanding trauma, things like art therapy, movement, trauma-informed yoga, managing nightmares, managing flashbacks, a whole range of different things. And every person's going to be different. We've had some people that have benefited just from one inpatient admission and felt that that was all that they needed. We've had other people that felt that they needed to schedule another admission, say 3 months down the track, and that's absolutely fine too. A lot of people kickstart their trauma processing in the containment or the safety of the hospital, and then we refer them out to do outpatient EMDR treatment with a psychologist or another clinician in the community, or with our outreach team that we have here at the Melbourne Clinic where people can see them in the community. So you might wonder, well, why would people come into hospital to do this? It's not a crisis program, so people are not acutely unwell or suicidal at the time. They're stable enough to come and do the trauma processing, but we find that some people don't feel comfortable to do trauma work in the community, and that might be because they might have found it was overwhelming when they've tried before, or they may just be quite frightened of the process, or it may just be that they have so much else going on in their life that they're not able to set aside the time in their everyday life to do this work. For example, in my private practice, which of course is outpatient treatment, people come and see me for once a week or once fortnightly sessions. Often people want to do this work, but then every time they come in, there's been something that's happened in their life. Their dog might have died, or there might have been a problem with their partner, and so naturally it gets a little bit distracted, if you like, and so other things come up. And so for some people coming into the hospital for a really kind of focused, intense 4-week period, this is what I'm here to focus on. There's no other distraction. That can work really well for some people. And certainly the clients that come into the hospital have daily sessions with their psychiatrists, with nursing staff, and just a lot more containment and support around the process as well. So with respect to who would benefit from our EMDR program, this also applies to who would benefit from EMDR treatment more broadly in the community. So you can see there's a whole range of different things there, which include single incident trauma right through to really complex experiences. So EMDR works much more quickly, of course, with single incident trauma that's impersonal. So that could be things like a car accident or a natural disaster. Then I suppose secondary to that would be interpersonal single incident trauma, so an assault, for example, or a rape. And then the most complex, of course, is repeated or complex trauma of an interpersonal nature. But EMDR is very helpful, but just over a lengthier period of time, and most helpfully when it's integrated with other approaches. So if you do hypnosis, or if you use CBT or other methods, by all means integrate them together, particularly in the preparation phase. A lot of the things that I do in preparation in EMDR, I draw on from acceptance and commitment therapy, for example, which is another method that I'm very passionate about. So it's not about you have to become an EMDR clinician solely. You can use it in an integrated fashion, and I think that being eclectic is the most helpful way to achieve success for our clients. So with regards to the EMDR program here at the Melbourne Clinic, if you have any questions about that, then you're very welcome to speak to me either about that this evening, or of course contact me on the number that's on the screen. And the brochure that's on the table there is for this program here at the Melbourne Clinic, which is our inpatient program. If you felt that you'd like somebody to be referred, or you're interested in the program here but don't think that the hospital setting is as most helpful, we do have an outreach team here, as I said, that do outpatient EMDR as well. People are most likely to benefit from this treatment if they have either private health insurance with psychiatric cover included, so hospital cover, so usually medium or top cover, or if they have another funding source like DVA or work cover, for example, because it's a private hospital. Does anybody have any questions about the program here before I talk about some other options for EMDR treatment?
Yeah, what percentage, I know it's a sort of a ballpark question, but what percentage of your patients do you think ought to be referred to inpatient treatment as opposed to...
Yes. Do you mean the people that I see here, or in my practice outside of the clinic here? Yes, just generally, sure. Look, my sense is that probably, I think, and this is just off the top of my head, I think only about 20% probably would really require an inpatient treatment. The vast majority of people are getting EMDR out in the community. So, 20 to 30% maybe. I mean, that doesn't mean that other people wouldn't benefit, but I don't think everybody needs it. I mean, it's a 4-week admission, so that's quite a commitment, of course, for people.
So as an inpatient, they literally are an inpatient staying here overnight?
Correct. So they're here as a patient in the hospital for 28 days. So they sleep here, they eat their meals here, they can go on day leave, they can have visitors, but they are in a psychiatric hospital for a month. Yeah. So it's for more complex clients. Yeah. Yeah. Any other questions about the program here at the Melbourne Clinic? Okay. So other options, as I mentioned, the Melbourne Clinic has an outreach team. Again, that would require a person to have private health insurance or another funding body, unless they wanted to pay privately, which is costly. So where else can you get EMDR treatment? Well, as I said, I work in private practice, so I'm out there doing it, and there's a lot of other people that are out there doing it as well. So they would be psychologists, clinical social workers, clinical OTs, psychotherapists, mental health nurses. There's a range of different practitioners. And on the EMDR Association of Australia's website, of which I'm the secretary, we have a Find an EMDR Therapist directory. And so if you go on that, you can search your local area and you can have a look at the profiles of the different EMDR therapists. And what I would recommend is when you go on that website, I would suggest selecting an accredited practitioner or a consultant, because what that means is that they have demonstrated a high level of competence and have been assessed as being particularly experienced and skilled in the method. Anybody really can call themselves an EMDR therapist if they want to, in the sense that it's not a regulated term, but certainly you want somebody that's quite experienced because of the nature of the work and what you're doing. So seeing an EMDR therapist would not be any different in the community to seeing another mental health practitioner. For example, you can go to a GP and get a referral under the mental health treatment plan or the Better Access scheme through Medicare, or you could just privately, self-refer, for example. So it's not that different, if you like, to going and seeing somebody for CBT or another type of therapy in the community.
Are there any contraindications to EMDR?
Good question. So I think probably the most important one would be a high level of acute risk. So if a person is suicidal or engaging in self-harming behaviours that are really risky, I wouldn't say that it's a contraindication forever, but at that particular time you would need to be focusing on that preparation phase. Things like active substance use, I think the jury's out a little bit on that one. Some people are happy to use it with clients who are actively misusing substances, but generally you want the person to be stable, to engage safely in trauma processing. If a person has difficulties with their eyes, for example, very, very occasionally if somebody's reporting eye pain, you don't want to keep going because there's been the odd case where you hear of a detached retina and things like that. I've never experienced that, but if a person's reporting difficulties with tracking or they're reporting eye pain, then you would need to move to another form of bilateral stimulation, which can include things like tapping on the client's knees in a bilateral pattern, left and right, or there are devices that you can purchase where the client holds onto little pulsing buzzers, for example, or has little headphones that they put on, for example. So epilepsy is another one that's a little bit curious. Again, we don't know for sure, but people generally suggest not doing eye movements with epileptic clients just for, just to be, cautious. So you might use another form of bilateral stimulation. Beyond that, the only other thing that we need to really be considering is dissociation. So if a person is highly dissociative, so they have a really strong sense of compartmentalisation within self, particularly if they have dissociative identity disorder, or formerly known as multiple personality disorder, we would use EMDR with caution, just because we don't want to overwhelm the person's internal system with too much trauma processing all at once. So it's not that you can't use it with those clients, but you would do it in a much more graded, slow process where that preparation phase, as I said, phase 2 in EMDR is a much longer process. Yes?
I'm hoping that you haven't already answered this question. Can, what's it called now?
EMDR?
EMDR
Yes.
be used as a self-help kind of?
Yeah, great question. Look, my recommendation, and this is consistent with my colleagues, is not to use it to process one's own traumas on your own. I think that that's a bit risky, particularly if you're a bit wobbly, in other respects, or feel a bit fragile. I know that I probably wouldn't feel comfortable doing that with my own, but certainly the concept of the bilateral stimulation, which is the eye movements, can be used for self-soothing and for calming. So there's a really great, or two really great apps that I'll mention to you now. One that's called Anxiety Release, based on EMDR. Which, as the name suggests, is an app which is useful for calming anxiety. And then there is another one which is called Sleep Restore. And both of them are available on the Google Play and the iTunes Store. They're both by a guy called Mark Grant, who was my EMDR supervisor for a couple of years. And the Anxiety Release based on EMDR app costs about $7, and the Sleep Restore app is much newer. It's currently free because I think he's just getting the bugs out. So basically what those apps are really fabulous for is using auditory bilateral stimulation, which is a sound, left and right, so you need to use earphones, to help with self-soothing and with calming the nervous system. So certainly they are a couple of apps that are really, really helpful, both for giving to clients, but also for using yourself. So for example, at the end of a long work day, if you're feeling like you're holding a lot of material, you can put that app in and just use it. They're guided, so he guides you through using it. Effectively what he's doing is he's guiding you to notice where do you feel tense in your body, and just to notice the anxiety, and then just to follow the sound, and just to let your brain do what your brain wants to do. And usually it helps to calm and to soothe. The Sleep Restore one is slightly different, but a similar concept to help settle the nervous system so that you can sleep. So those are self-help in a sense, but they're not to be used for processing trauma, just because we don't want people to be getting destabilised in their own lives. There is also a fabulous book by Francine Shapiro, who was the developer. Which the name actually escapes me right now, but if you were to just Google Francine Shapiro EMDR book, then there is a book which is certainly an excellent book for lay people in the community. So her name's Francine Shapiro. So if you just Google her and EMDR book, you'll find that, no problems. So it's not a theoretical professional book, it's more a self-help book. You'll get a sense of that when you look that up. So those are some options that are available.
I was just wondering if all psychologists use EMDR or only the ones that have an interest in it?
It's a really interesting question, and certainly the answer is no. No, not everybody uses this. And so back when it was first developed, it was very, very niche, to the degree that people were scoffed at, I think. I mean, Francine Shapiro herself was accused of being fairly proprietorial, to be honest. She didn't have a great name initially, but, she's gone on to be a woman of great, be greatly respected by the community. But EMDR is not that widely practiced comparative to the number of practitioners that are out there, but more and more people are training in it. I don't have percentages of the number of people out there in clinical practice that are using it, but certainly it's not like CBT, for example, which is taught in every psychology degree, for example. EMDR has I guess essentially has been very niche to people that work in post-traumatic stress, but increasingly is being used more and more, and therefore being taught more and more. And I know this because I facilitated trainings and I also supervise a lot of people, and I'm inundated with people who are learning it now, which is very interesting and exciting. So, with regards to how you can actually become trained as an EMDR therapist, you can engage in what they call the EMDR basic training program, which is usually across 2 workshops, usually either 3 or 2 days and then another 2 days, and then 10 hours of supervision or consultation, and that's considered to be the basic training program. So it's 20 hours of training didactically, 20 hours of practice in the workshops, and then 10 hours with a consultant, who is accredited by EMDR. And so usually, as I said, 2 workshops. You can start practicing EMDR before you've completed that full basic program. Once you've done the first workshop, which effectively is going to be half of the 40 hours that you'll see in the top 2 dot points there, you can start practicing, but you're not considered to be an EMDR therapist that's fully trained until you've completed all of that. And so if you are interested in this training, then on the EMDR website there is a list of training providers, and certainly here in Melbourne there are ample opportunities to do that training. I do a lot of training assistant work with someone called Graham Taylor, who I would certainly recommend, and there's also others of course that are listed up on that training provider website. It's not that cheap, if you like, to do this training, in a sense that you are required, of course, to attend a number of workshops. So just a ballpark figure, I think probably would be around about, sort of $600-700 for a first workshop perhaps, and then around about sort of $500-600 for a second, and then to engage in 10 hours of consultation. Obviously, most supervisors will charge up to $150 an hour perhaps. So, it is a financial investment. But what I certainly can say from a marketing perspective, if you like, is that EMDR is very in vogue, and it is becoming very, very widely respected and well known. So if you are in private practice, or if you are wanting to sort of develop your business or your practice, I'm not sure where you work, but it's actually a very strategic, very sensible idea to train in EMDR, because it is very, very well respected increasingly these days, and it's niche enough that not everybody is doing it. So it means that it sets you apart from other practitioners, which is excellent. And obviously the most important thing is that people are benefiting from it. It's excellent. People are previously engaging in years and years of therapy just to talk about the same old traumas over and over, and this is offering an opportunity to process that in a much more swift and painless way, which is very exciting. Does anybody have any questions about the process of training in EMDR?
Yes, I would be interested to know. I have a particular hobby horse of mine in clinical hypnotherapy is that people go through a training process and they practice on each other in the classroom. And I've always thought it would be a good thing if a newly qualified or somebody in training actually went with an experienced qualified practitioner and sat in the corner and watched live. It's all very well doing it with your classmates, but it kind of loses its edge slightly. Do you advocate that sort of teaching process, or
with real clients, do you mean? Yeah. Look, if it's feasible, then of course that would be ideal. I mean, here at the Melbourne Clinic, I as coordinator observe all of my clinicians in their sessions with their clients. We also videotape sessions, and then we watch them back over the course of supervision together, and then discuss things. It's not always feasible, of course, to do that, but I think it would be ideal, wouldn't it? Absolutely. So, and certainly in EMDR work, I think it's very, very important that you do have support as you practice this, because it's a sort of thing that's kind of strange and new, and so people often end up feeling a bit de-skilled and a bit sort of, a little bit clunky, and so then often you get back to your workplace, there might not be other people who are trained in it, and then you lose your nerve, and then it's the kind of thing that if you don't start practicing it pretty quickly, then you lose confidence. And so I think having other colleagues that are training in it too means that you can talk together among yourselves, and certainly I'd encourage participating if you're interested in the special interest group that we have here in Victoria that's part of the APS, Australian Psychological Society. You don't need to be an APS member, but if you're interested in EMDR from a therapist perspective, it's a professional group that involves clinicians clinicians coming together once a month. If you're interested in that, by all means, speak to me and I can give you details about that. But we practice together, I suppose, in that setting, not with real clients in the room because obviously they're not there, but you know, I think wherever possible, it's important to be keeping each other accountable and practicing.
You know, I mean, it just reminds me, because I've come from a medical science background in the old days, you know, 100 years ago, where you kind of went on rounds and the consultant was there with questions for five, and patients very rarely objected. I mean, I know some of them probably felt they could have objected.
Yes, yeah.
But generally, I've always found that if you say to a client, a patient, or whatever they call them, you know, we've got something training, do you mind? Most people are pretty open to that.
Sure.
And I would like to see a lot more of that in this sort of environment where we kind of do sit in the corner, we do see a seasoned practitioner. You know, you don't obviously don't interrupt, but you just absorb what's going on, which is so much better when it really is a live
Absolutely,
client.
yeah, well I agree. So where that's feasible practically and also where a client gives permission, then absolutely. Like in group practices, for example, that might work, and certainly we do that at the clinic here. And obviously the other option is videotaping sessions, either of watching a more seasoned practitioner on video, or you know, vice versa, the newer therapist can be videotaped with a client and then the supervisor watches back and gives live, you know, not live feedback, but you know, gives feedback. You know, ideally we have those two-way screens where you can be watching on, but not everybody has the luxury of having that set up in their practice. So, yes.
One question. I noticed earlier on with the clinic here, you've got 90-minute sessions.
Yes.
Now, surely you don't do this for 90 minutes, because it'll drive someone mad, the person doing it.
Yes,
So
yeah. How much of it is eye movements? Is that the question?
Right.
Yeah.
So in 90 minutes, what do you cover? Like,
Yes.
How many minutes of this do you do?
Yes. Well, it's probably difficult to say exactly how many minutes, but it's certainly interspersed throughout the session. So usually what you'd start with in a session, remembering that not every session is going to involve eye movements, there's going to be preparation and other things. But when you're in that phase, which is phases 3 through 6 particularly, you would spend certainly the first part of the session, like you would with any person, just checking in how they've been going, establishing a focus for the session. So that obviously is going to take a few minutes. You then determine together what you're going to work on and then call it to mind and activate it. So that obviously takes a little bit of time. You might take a few minutes to determine what thought best represents the negative belief that goes with it, and that takes a bit of, you know, nutting out sometimes. So usually I'd say that the eye movements would be, you know, intermittent for probably, you know, an hour at least, but you're having periods of reflection and pausing in between. So you have these, we call them sets of eye movements. So you're not just doing this for 90 minutes because your arm's not going to survive and the client's going to lose their mind, but you know, you would have, you know, up to 20 or 30 or more sets of these eye movements, but you're pausing in between, which often is just a very quick check-in, but sometimes there can be a few minutes of discussion. So it's a sort of stepping in and out of it. Most clients do report feeling very, very tired though at the end of an EMDR session, and for therapists can actually be quite a process of repetitive strain on your body. So, you know, we need to be quite conscious of that, and there's certain things we can do to you know, mitigate the risk.
Mechanical arm.
You're correct. Like a Go Gadget Go type of arm or something. There are wands that people use, there's light bars, you know, there's all sorts of things. It's quite an interesting business really. So.
Does Graham Taylor, the person you mentioned, does he run workshops very often?
Yes, he does actually. I think he ran 32 EMDR workshops for trainees last year alone. So he's incredibly busy, and he's based in Perth, but he does come to Melbourne regularly. In fact, today he's running EMDR training here in Melbourne.
The 20 hours, is that like all in 1 week or?
So as I said, there's usually 2 workshops, that the 20 hours of didactic training, 20 hours of skill training. Usually people would do the first workshop and then have a period of putting it into practice for maybe 3 months, 6 months, and then you come back and do the advanced. So effectively it's introductory and advanced training. Yep. So you can't do it all in one go. And the 10 hours of consultation, in order to be considered to have completed the basic training package, which means that you could be listed on the Find a Therapist directory on the EMDR website, for example, it needs to be with a supervisor like myself or like Graham, or there's others that are listed on that same website who are accredited as supervisors. Yeah.
Can I ask, if you're saying that the training is paced over a period of months, does that mean you can pay over a period of months as well for training, or is it all?
That would depend on the training provider. Yeah, I'm not quite sure how they work. Usually they would require payment up front, I would suspect, but there might be some negotiation for payment plans.
That makes it a lot more doable for
yes,
lots of people.
Of course, absolutely. Yeah, yeah. So Graham Taylor quite recently has just rolled out the first online training options for EMDR, which does include live webinars, because he does need, of course, to be observing you practicing, because 20 hours of it is actually practicing. It's not just sitting in a lecture theatre, you're practicing on each other, and that's a bit contentious actually. A lot of people don't agree that it should be online, but I guess it's about being accessible for people, making it a bit cheaper, and people particularly in rural areas are more able to access the training that way as well. So I'd just like to invite any other questions about EMDR. I mean, this has been just a very, very broad brush presentation. Any questions about what the treatment looks like? I'm really sorry that the videos weren't able to be shown, because I would have loved to have shown you, what it actually looks like. But
I'm thinking it maybe contained the answer to the question, maybe contained in the training. I was thinking about a legal perspective.
Yeah, yep. That's a great question, and actually with respect to the contraindications, I failed to mention that before, that it's not something that we need to avoid at all costs, but if a person is likely to be giving evidence in a criminal court process or in any court process where the subject of the EMDR treatment is what they're